So good evening, doctors and all the participants. Shumon on behalf of Shield Healthcare, I welcome you all in today's another session, the Icons in Conversation with Dr. Ritu, and the topic of the program is early pregnancy scan. So it's our honor to introduce ma'am, although ma'am is very well known. Just to introduce, madam is a senior obstetrician and gynecologist and IVF specialist, and she is the founder and CEO 360-degree healthcare studio in Ahmedabad Multi-Speciality Hospital, Pune, and infertility specialist in UJS, Singapore. And Madam is the co-founder, ma'am, board member of WSCG. And it's time to introduce Sir, Dr. Kuldeep Singh Sir. Sir is very well known. And he's the master trainer in the field of ultrasound. He has more than 300 talks in national and international platform. He has received many awards in the field of ultrasound. Many books he authored in ultrasound in obstetrics and gynecology and infertility. And Sir also received the Imaging Science Award in the AICOG in New Delhi. And Sir is successfully running this Sono School, which organizes various training programs in the ultrasound, in the obstetrics and gynecology and infertility. And Sir is going to launch his latest venture, VQUL, that is VQ Question, You Answer, and Learn, which is going to cater to basic and advanced academic programs. So with this short introduction, I request Sir, Dr. Ritu ma'am to take over the session for further proceedings. So thank you very much.
Yeah. Thank you, Dr. Suman, and thank you, Shield Pharma, for providing the platform. A big thanks to dear Chitra, who always help us for getting the program YouTube live, because whatever the knowledge the doctors who can't join at the same time can see later on the YouTube. So very warm welcome to all of my dear friends who have joined all across the geography. Today with us, none other than Dr. Kuldeep Singh Sir is with us. Sir is the ocean of knowledge, teacher of teachers. A very, very warm welcome to you, sir. Sir, so many friends have joined via YouTube also, the program, as you know, going live on the YouTube also. So when I posted for the program, so many appreciations already have come from lot of the Saudi, Middle East countries and from the KU also. Some of friends have joined here also, but mostly they see via YouTube. So friends, today's topic, as you all know, is the early pregnancy scan. So as you know, this my series, the Icons in Conversation with Dr. Ritu. In this, we take every time we take one particular topic, and for that we discuss with the stalwart. So this early pregnancy scan is actually a dilemma for all those gynecologists who are going in the field for the sonography. आज से around 15 years back when I started doing the sonography, तो हमारे मन में भी बहुत सारे questions होते थे. Sorry, I will speak in English because program is going. So a lot of questions in everybody's mind. So today we are going to start from basic to advanced. So I think Sir is the best person for that, to guide us for all this. Sir, you can see a lot of our friends have joined all across the geography. A very, very warm welcome to you, sir.
Thank you so much, Dr. Ritu, and it's always a pleasure. And you know, I can never say no to you because it's always a fantastic program, and the topics that you always choose are very, very good. So I hope there would be the delegates who joined from all over, plus those are there in front also. They would be benefited, and because the early pregnancy scan is something which is very, very useful. Let's not start off only by doing an NT scan, or let's not start off, okay, anomaly scan and that's enough, because there's so many things which you can catch. There may so many things which you need to know, because as we are going to be a little more comfortable in our early pregnancy scans, those are going to help us for our later scans as well. Dating extremely useful and necessary. And after that, one doesn't realize it. Should I call this pregnancy? Is it okay? Not okay? Am I going to be suspecting some trouble? Then where exactly is the pregnancy? There are plenty of questions. And you rightly sent me so many of these questions, which we're going to be addressing today. So this is again, thanks to you, Dr. Ritu, for organizing such lovely programs.
So pleasure is ours. We are honored to have you with us. Earlier also, I have done 3 academic marathons, 4 academic marathons, all were gone very super successful. In every academic marathon, there was a lecture by the sir. So sir, I am really honored to have you with me. So friends, today's our session is based on the question answer. So what are the normal questions we are getting? What are the questions in everybody's mind? Those ones starting for doing the sonography. So sir, with your permission, can I start the question?
Absolutely, absolutely.
Yeah,
Do you want me
yeah.
to start sharing the screen as well?
Yes, sir. Yes, sir.
I'll do that. And then again, a request to everyone that the moment you feel that there is a question that you need to be addressing, you need to be looking at, please keep on writing it. Otherwise, you can just unmute yourself. And in between also, if you need to, then when Dr. Ritu asks for, then you can ask your questions as well. Right, I hope you all are able to see the screen and you're able to hear me.
Yes, sir. Yes, sir.
Right, so we start off with that, and the introduction has already been given, and we're going to have this question and answer scan in early pregnancy scans. Yes, Dr. Ritu, the first question.
Yeah. So first question in everybody's mind, is there a pregnancy? And once I'm going to do the sonography, so will I able to see it? Because in our practice, so many patients are coming, all are doing the pregnancy test at the home and telling, ma'am, my UPT is positive. So first we have to confirm via the sonography whether the intrauterine or extrauterine. So sir, we will start from the basic only, that how to diagnose that if there is a pregnancy is there or not.
See, the moment the patient is coming to you, irrespective of whether they've got a urine test done or not, we're going to first ask them the history of amenorrhea. We're going to have at the back of our mind, yes, are we looking at or are we going to be suspecting a pregnancy or not? You're doing your examination, but you need to be doing a urine test. But if it is positive, let's say if it's faintly positive, you need to remember, if you just straight away ask for a scan and the patient is not symptomatic, we're not going to be able to see a pregnancy at that time. Not seeing a pregnancy does not always mean that there is trouble. You need to remember, and that's what I have the second slide on, where you're looking at an absent intrauterine sac with a thick endometrium. So you've asked for a scan, you'd say the urine test is positive, or that's what sometimes the patient comes in for. Nowadays with the PNDT, we can't be doing an ultrasound without a referral. But you also, as all obstetricians and gynecologists, need to remember that it's not always with the urine test you're going to be finding a gestational sac. So you always need to be getting a beta HCG done, and you have to make sure that it's above the discriminatory zone. So if you're looking at just a trans-abdominal scan, then you're going to be looking at least more than 4,500 should the beta HCG be, where you're going to be suspecting there should be a pregnancy. The book says 6,500. I normally say, and nowadays we have such lovely machines, it should be more than 4,500. And if you're doing a transvaginal scan, definitely more than 1,500 before you start getting worried. If she's come in pain, if there's something else to it, yes, obviously, then you're going to be a little more worried about it. But if everything is routine and you're not able to see it, just call the patient back again after 72 hours with the beta HCG report and with the ultrasound as well. So if it's below the discriminatory zone, do not panic unless and until she's symptomatic. Call the patient back again. And this last important slide, if you see over here, for the first question is, in an ectopic pregnancy, that's what we're worried about. A slow rise in beta HCG level, the normal rise is around, it doubles or 1.7 times, or at least 53% in 48 hours. But always and always remember, 5 to 8% of ectopics will still have a living embryo with normal levels of beta HCG. So you need to be very, very watchful. Don't panic and make the patient panic. Ki nahi, ye ho sakta hai, wo ho sakta hai, this can happen and that can happen. When it's just a matter of timing, that it's a very small pregnancy, you're not able to see it.
So friends, we have to notice this point, what sir have enlightened with us, that 5 to 8% of the ectopics will still have a living embryo with the normal levels of beta HCG. Because today in the era, most of the patients are doing the urine test also. By Googling, they are coming with the beta HCG report also. And sometimes, especially if the youngsters are coming to us for the termination of the pregnancy, they are not ready for the sonography. Madam, we have already done the urine test. We have already done the beta HCG. Why you want to do the sonography? So we have to emphasize and clarify to all of our patients and for our knowledge also what's the importance of that. So thank you so much, sir. So related to this, now coming to my next question regarding for the ectopic pregnancy, how to localize whether the pregnancy is in the uterus or it is outside the uterus.
Before this, Dr. Ritu, you had a very, very valid point that if somebody has come for a termination and these youngsters can sometimes create havoc. That is the difference between they coming to a doctor who's going to be giving them a complete broad overview rather than going on to the on-the-counter medicines and doing something wrong. And then they come back with there's a ruptured ectopic or there's some other problem. So let's be very, very clear. The ultrasound has to be documented. And that was a very valid point that you put in, Dr. Ritu. So now if we're trying to look at in the uterus, the goal of first trimester screening, we need to be looking at whether there's an intrauterine pregnancy or not. An ultrasound, extremely sensitive and specific. And if you are going to be looking at the first very sign, which is like an indirect sign, will be an asymmetrical thickening of the endometrium. Because the gestational sac is not going to be in the cavity, it has to be embedded in the endometrium, anterior or posterior. So you're going to first find that, yes, I'm looking at an asymmetrical thickening of the endometrium. The first positive or a direct sign would be when you're looking at an intradecidual sign. So this is when you're looking at a thickened endometrium, and if you switch on your color, sometimes it's not that it's recommended for all patients, but if there is some query and you need to be figuring out, just switch on your color and you'll be able to see this sort of a comet sign, meaning we can't see a gestational sac, but this is a start of the whole thing. So you need to be very watchful. And this is what you're looking at. This is the cavity. This is the anterior endometrium, posterior. If you see a pseudo gestational sac or a fluid collection, it will be in the cavity. But if you see, this is embedded over here. That's the cavity. It's not there. It's in the anterior endometrium. And that's what we call an IDS or an intradecidual sign over there that you're looking at. So this is the first sign that you're going to be looking at. Second would be because the cavity is not getting displaced in the intradecidual sign, but when the sac grows in size, there's going to be displacement of the cavity and you're going to find a DDSS, which is a double decidual sac sign. This is how you're going to be looking at the evaluation in the beginning. Yes, I'm sure it's in the uterus and I'm comfortable with it.
Yeah, thank you. Thank you so much, sir. Sir, there is one request on the YouTube. Please kindly show the previous slide once again for the double decidual sac sign.
The intradecidual sign, the written format there.
Yeah. Yeah. Thank you. Thank you so much, sir.
So that's the double decidual sac sign. And over to you, Dr. Ritu, for the next question.
Yeah. So now we have seen that how we are going to diagnose the intrauterine pregnancy. Now the question comes, is that the intrauterine pregnancy, this is normal or not? Now, sir has very clearly shown us by a small video also. So now this question is coming that how to diagnose that the intrauterine pregnancy is normal or not?
See, when you're looking at, you've seen an intradecidual sign corresponding to around 5.5 weeks, you're comfortable. Double decidual sac sign, there you're looking at a double decidual sac sign. Now, if you see over here, the first thing that appears is a gestational sac, the IDS, then double decidual sac sign, and then inside you're going to be looking at, this is a yolk sac. Then adjacent to it, if you see, there'll be a small embryo, which I'm not going into too many details right now because we'll discuss abnormal much more. But if you see over here, you're looking at an embryo over there. So that is a diamond or a signet ring stage where on one end of the yolk sac, you're going to be looking at an embryo. Initially, there could be peristalsis, then there would be a little, I won't say bradycardia because it's normal for that stage. Till 7 weeks, even if you're looking at a heart rate of between 100 to 130 beats per minute is normal. More than 8 weeks, definitely should be more than 130 beats per minute. So this is how is the first step to looking at normalcy of a gestational sac.
Very clearly shown, sir. Thank you so much, sir. You are clearing the basic concepts very nicely.
Thank you, Dr. Ritu. Now,
Yeah.
over to you for the next question.
Yeah. Sir, now when we can label the pregnancy as the abnormal pregnancy?
The thing about here, Dr. Ritu, is, and for the delegates, all the delegates, is don't be overzealous in labeling a pregnancy as abnormal.
Okay.
Every baby, every pregnancy, every embryo is extremely precious for their parents. So if you're not very sure, there is no harm in calling the patient back again. Don't label it abnormal and terminate it, because there's set standards. And the ultrasound diagnostic features of an early pregnancy loss, if you see, when you're not looking at any cardiac activity, but the crown rump length has to be more than 7. So 3, 4, 5, please do not label them that there is a problem, because till 7 millimeters, you could be not seeing a cardiac activity and then it's going to appear later. If you're seeing over here, it's a big gestational sac, and obviously this is the embryo, which is much more than 7 millimeters, no cardiac activity, you're sure of, and then you do not repeat the scan, or you do not need to repeat a scan in this. Then we have the other criteria. You're looking at a gestational sac larger than 8 millimeters on a transvaginal scan, or more than 15 millimeters on a transabdominal scan, and you do not see a yolk sac, that's a sign of early pregnancy failure. You're looking at a large gestational sac. And when I say a large gestational sac, I need to be measuring it. More than 8 millimeters on a TVS, more than 15 millimeters on a transabdominal, and I need not to take only one measurement, but 3 measurements, and take a mean sac diameter. Inner to inner is how you're going to be measuring your gestational sac. And see, there is no yolk sac inside. This is much more than 8 millimeters because it's a transvaginal scan, and I'm sure of that I do not need to be looking at it again or calling the patient back again. Another example of the same thing. Then we come on to the next type of thing where you're looking at a gestational sac larger than 16 millimeters on a transvaginal, more than 25 millimeters on a transabdominal. Whenever I'm saying these figures, it's a mean sac diameter, and I do not see an embryo. Meaning I could be looking at a yolk sac, but no embryo. I know I'm looking at an early pregnancy loss over there. I can see a yolk sac, but I cannot see an embryo, and this is much more than 16 millimeters on a TVS, or more than 25 millimeters on a transabdominal scan. Then there are few more newer things coming up. You've seen an embryo, you repeat a scan after 7 days. First time you were not looking at a cardiac activity, but after a week it should definitely come up. Or if there was an embryo with a heartbeat, and next time whenever you look at it, you do not see a cardiac activity, definitely an early pregnancy loss. So you need to be clear about these 5 findings before you call it an early pregnancy loss and terminate it.
Very nicely. Sir, but sometimes once we do the sonography, we found the eccentric gestational sac. So what does it signifies?
That I'm going to be coming on to it, Dr. Ritu, but before that, we'll just talk on a few, I'll just show you this.
Okay,
and then
okay.
there are a few things where you're going to be looking at, we're not very sure, but we're suspecting that this could give a problem. That's how you sent me the question. I'll just show that to you. But before this, if you see, there are these 3 gestational sacs. No yolk sac but no embryo, and this shows normal yolk sac with nice cardiac activity. There. So this was basically the next question that you sent to me was, it's approaching towards an abnormal pregnancy. It's suspicious, but not diagnostic. Meaning, should I be really careful? Should I call the patient back again? I'm not going to be terminating it, but I'm still dicey. So what you're going to be looking at, if it's less than 7 millimeters, crown rump length, but no heartbeat, or you're looking at a mean sac diameter less than 25 millimeters without an embryo, you're still going to be suspicious, call the patient back again. Or if you're looking at an empty amnion sign, you first have a yolk sac, there's an embryo forms, is going to get an amnion around it, then the yolk sac and the embryo go farther away. The embryo is going to be in the amniotic sac, and the chorionic cavity with the yolk sac is going to keep shrinking. So if you have an empty amnion sign, you know we're looking at trouble. You're looking at a large yolk sac, we're looking at trouble. You're looking at an oligoamniotic sac where the mean sac diameter minus the crown rump length is less than 5 millimeters. You're going to be calling that as findings of an impending early pregnancy failure, and I'll show you a few cases. This is basically eyeballing. If you see, you're going to do the measurements, but the moment you feel the gestational sac is full of the embryo or fetus, you know it's an oligoamniotic sac. That's a corpus luteum there. We're looking at nice cardiac activity. We're looking at everything fine, but like in the beginning is less. Please call them back again after 2 weeks. The gestational sac is full of the embryo. Looking at bradycardia. Where my arrow is, that's pointing towards the cardiac activity, and we can see that. You're looking at a large yolk sac. This one is normal yolk sac. Cardiac activities were fine. There's a subchorionic hemorrhage, but this finally landed up into the cardiac activity going absent, and this progressed nicely. Whenever in doubt and you're not able to see anything, just switch on your color for a few seconds. That's only when you are really very unsure. You'll find this hot vascularity around the gestational sac. That again means you could be looking at trouble. Oligoamniotic sac, and this is a very nice chart which shows you what should the cardiac activity be. So if you're looking at even in less than 100 in the beginning, you know chances are there could be trouble. The moment you're going more than 7 to 8 weeks, it definitely has to be more than 120, 130 beats per minute. When you're looking at there is no embryo inside, that's an empty amnion sign. But if you're looking at no cardiac activity and an expanded amnion sign, you need to be careful. So this is how you really need to be. I'd put in this question before Dr. Ritu, whatever you'd asked for, because I felt these two are going to go together much more nicely. So that's how you're going to be looking at suspicious of, but not a pregnancy failure. Ji, doctor. You'll need to. Ajay.
Yeah. Thank you so much, sir. Very nicely you have shown. Sir, I have received, the same question I have received via YouTube also for the eccentric gestational sac. Yeah.
See, eccentric gestational sac would mean if you're looking at the gestational sac, it's the ideal state would be in the fundus, you're looking at in the center. But if it is on the side, again, does not always mean there is trouble. If you're looking at this portion over here, it's supposed to be here, but if you find it here or here, you know that's an angular pregnancy. But again, it could go a little more lateral and the definition changes. So you need to be watchful for when it is here. Because over here means it's in the endometrial area, in the cavity. It's not in the myometrium, and there's a thick enough myometrium lateral to when I show you a gestational sac. It's wonderfully seen on a 3D, but you can easily suspect it on a 2D as well. I'm looking at in the center, nothing seen over here. The moment I angulate the probe, there you're looking at a transverse section and you're looking at, this is the gestational sac on the side, not in the center. And you always and always need to be watchful that let me just take a pen, that your the vaginal probe is always an end firing transducer. So the moment you're going to be tilting in the center, you're looking at in the central portion, which is here. But if you need to tilt it, but you're looking at endometrium lateral to it and plenty of myometrium, more than 5 millimeters, you are comfortable that it is an angular pregnancy, not an interstitial ectopic pregnancy, which I'll show you just now. There, see that over there. That's going to be much more easily seen on a transverse or an axial section. More laterally placed is the gestational sac over here. Eccentrically, in contrast to interstitial tubule, they have much more myometrium, and basically it's an intrauterine implantation. Not that we do not need to be careful, we need to call them back again, because if it starts growing laterally, we had it, and there's no way we can say that it has to grow this side. A 3D ultrasound, definitely much more helpful there. So you can look in at the myometrium lateral to it. There should be a normal myometrial coverage, usually more than 5 millimeters, because it usually tends to grow towards the endometrial cavity, towards the medial. We do not get worried about it, but call the patient back again. Tell them that if you have any symptoms, you need to be coming immediately. Now, this was where the angular pregnancy was. But if you go on to the side, this is where the interstitial. What happens is the tube is coming, and then the myometrial portion of the tube, if there is an implantation there, that's when you call it an interstitial pregnancy. That's where an interstitial pregnancy would be. You need to be going even more lateral. Nothing seen over here, and there you see that. Absolutely outside the endometrial cavity, that's when you need to be watchful. And this is more like an ectopic pregnancy, not seen in the endometrium, outside it. And you'll be able to see this interstitial line sign. That's basically the tubal area that you're looking at. And basically it's an intramural ectopic. Intramural would mean myometrial ectopic pregnancy, and the chances of rupture and hemorrhage are quite high. You're going to be looking at this interstitial line sign. That's basically from the endometrial cavity to the gestational sac. That's the interstitial line sign. The last portion where you're going to be looking at in this is that the myometrium is going to be less than 5 millimeters. Next portion, you've seen angular, you've seen interstitial. Normally what we used to call the angular interstitial, earlier on we used to call that as cornual pregnancy. These are the latest definitions. And if you're looking at a fundal implantation in an anomalous bicornuate or septate uterus, is when you call it cornual pregnancy. Looking at on the right, in the right horn, that's a septate uterus because there's no dimple over here. Again, the right horn, plenty of decidual reaction. So this is basically when you're looking at the angular, interstitial, and cornual pregnancy. So you need to be defining them. You need to know what do we need to worry about. Only the interstitial we need to worry about. Angular we need to be careful about. We call them back again after 2 weeks. And once we see it's growing medially, we're comfortable. Cornual, you just need a routine, normal follow-up. Ji, Dr. Ritu.
Thank you so much, sir. Sir, now my next question, which is the dilemma in everybody's mind. So how to diagnose for the scar pregnancy, how to diagnose for the cervical pregnancy?
When we're looking at, because there's so many of these cesareans happening, people conceiving later part of their ages, as I would say, then the other thing is cervical pregnancy, and there's always this question whether is the gestational sac come from top to bottom, that means it's an abortion in process, or is it a cervical pregnancy? So if you're looking at a cervical pregnancy and you see it's an empty uterus, you're looking at an hourglass uterus, a balloon cervical canal, because it's there, so it's going to grow in size. You're looking at a sac and the cervix. The internal os is closed, because if it's an abortion in process, the internal os would be open. And you're going to find flow around the gestational sac. The most pathognomic sign is if you're looking at cardiac activity below the internal os, highly suggestive of cervical pregnancy. Then the sliding sign, if it's an abortion in process and you're going to be just probing it, a gentle probing, you're going to be finding the shape gestational sac or the position could be changing. While in a cervical pregnancy, it's not going to. There it's in the cervical canal, that's the cervical pregnancy. When you're looking at abortion in process, there's going to be a sac in the cervical canal, but there's going to be no vascularity around. The sac could be irregular and the os could be open. There's going to be no cardiac activity. And again, the sliding sac sign, you're going to be able to change the shape and the location. Next thing that comes on and is very important is the scar pregnancy. The uterine cavity is not going to show up anything. The gestational sac is going to be embedded in the scar niche. The same isthmocele that you see, you're going to be finding that's of least resistance, and the gestational sac tends to go inside. There's going to be thin or an absent myometrial layer, plenty of Doppler signals, and the sliding organ sign would be absent. There, see that. This is the gestational sac in the scar area. That's the fundus, that's a transabdominal scan. You're looking at this beak sign over there. That's basically of least resistance trying to go in. In fact, you can see a yolk sac and the embryo over there. That's the beak sign. You're not looking at in the cervical canal. This is in the scar area. Plenty of Doppler signals seen, and you can see the myometrium is thinning anterior to the gestational sac. Over to you, Dr. Ritu.
Thank you so much, sir. Very nicely you explained, and videos are very, very self-explanatory. So thank you so much, sir. So now this is again a very, very important question regarding the tubal ectopic. Every one of us getting the patient of the ectopic pregnancy in the OPD, ovarian ectopic, tubal ectopic. So sir, please elaborate to all of us that what are the important features we have to focus while doing the sonography for the tubal ectopic.
See, what I always say, if it's above the discriminatory zone, the patient is not bleeding and you're not able to see an intrauterine gestational sac, it has to be an ectopic unless and until proved otherwise. Because if you're looking at a 2500 or a 3000, patient is not bleeding, because if the patient is bleeding, it's quite possible the gestational sac has come out, and earlier on it was 6000 and now it's dropping. So if the patient is not bleeding, symptomatic or not symptomatic, you need to be clear in your mind that there has to be a pregnancy somewhere, and I should be able to see it on a transvaginal scan. That's the common the picture that we always see. It could be an interstitial, isthmus, ampullary, but we know the most common site is going to be the ampullary ectopic. 70% of them are going to be there. If you're looking at an adnexal mass, that is separate from the ovary. One of the most common findings. And if you are able to see a yolk sac or a living embryo, we know that's pathognomic. It's not always that you're going to be able to see it. So you need to remember that in so many of these cases, you would not be able to. So you need to explain the patient. It's not that, okay, if I can't, let me do an exploratory laparotomy. No, might be there's something more to it. So just get it repeated, explain the patient about what all signs and symptoms should you be careful about, explain to the relatives also, so that if there is a hassle, they can, and please write it in your notes as well or in the prescription. So that next time, whenever the patient, supposedly, let's say out of 100, there could be 2 who have a problem, then they're going to be after our lives. Normally, wherever the corpus luteum is, that is the side where the ectopic is going to be. You could sometimes be looking at a hematosalpinx as well. You could be looking at a 2 to 4 millimeter concentric echogenic rim. That's what we call the tubal echogenic ring. You could be looking at a ring of fire sign. Color Doppler can also have it, but then you need to be careful that you're looking at 2 such areas. You could be looking at a hemoperitoneum or large amounts of free fluid. So if you're looking at that proper with a gestational sac, that's a tubal ring or a bagel sign. But if you just look at the adnexal mass, which is usually the commonest feature, it's a blob sign. So if you're looking at an extra ovarian adnexal mass, which is quite vascular, please suspect that you're looking at an ectopic. Transvaginal possible tubal ectopic, when you're looking at an empty uterus, there could be fluid which you call a pseudo sac, but please take into account clinical presentation, beta HCG levels, and the uterine and adnexal findings. See over there, nothing in the uterus. Ovary, that's the other ovary, and you see a mass over there with a yolk sac. On the right side, that's the iliac vessel, that's the right ovary, that is the uterus, and you're looking at an ectopic over there. You're looking at, that's the cardiac activity. You're looking at a mass over there, and you're looking at a yolk sac and cardiac activity, ectopic. A bigger pregnancy, cardiac activity almost 8 weeks. And you're looking at an ectopic pregnancy. The adnexal signs, again the same thing. Thick echogenic rim, central anechoic area, low resistance vascularity. If you see a gestational sac, voila, then you're very, very comfortable. But there's so many times where you're going to be looking at free fluid. Now see over here, you're looking at an adnexal mass. You're looking at a pregnancy over there, that's a corpus luteum separate. And huge amounts of fluid that you're going to be seeing. You can see up to, that's the liver and the right kidney in the hepatorenal space. So almost 1.5 to 2 liters of blood definitely is there. So you need to be watchful. You need to get the whole system and the OT prepared for this. There you're looking at a corpus luteum, and you're looking at a separate mass over there. 2 ring of fire signs with no stimulation, 1 corpus luteum, the other is a gestational sac. The uterine signs, we always think of adnexal signs. There should be uterine signs also, and there are, where you're going to be suspecting. You're looking at an empty endometrial cavity. You're not looking at a thickened endometrium. Symmetrical endometrial cavity. If there's a gestational sac embedded, it should be asymmetrical. And if you're looking at a pseudo gestational sac in 10 to 20% of cases. And how do you differentiate between the two? There's no double decidual sac sign. There's a change in shape with uterine contractions. It's bang in the center, and there is no flow around it. So friends, in an early pregnancy scan, please be very watchful. What is going to be normal? What is abnormal? There could be abnormalities in location. There could be abnormalities in terms of the cardiac activity, the sizes, and how to interpret that. And there are so many times where you could be looking at trouble, especially in the tubal area. Just be a little watchful. Don't jump onto saying things are abnormal. Go methodically and you'll be able to do a good job. The first and foremost is when the patient has come to you, what are the symptoms? What is the biochemistry like? What is a urine test? And don't always believe what the patient says. You are going to be listening to all that, but remember, whatever you are going to be checking and doing, there are plenty of false positives. So be watchful so that you do not make a mistake. Ji, Dr. Ritu.
So thank you, sir. Whatever the questions I have in my mind for the early pregnancy, you have covered each and everything. Dr. Suman, can you please check if there are any questions are received? Meanwhile, I'm checking on the YouTube.
Madam, one question I can see that.
Yeah, please
sir,
check it.
In the chat box, ma'am. Sir, is there always peritoneal fluid seen in ectopic?
No, that's definitely not. Unless and until it's a tubal leak, a tubal rupture, no. In fact, most of the times when you're initially going to be seeing a gestational sac, till the tube goes plop and there's not going to be bleeding. Sometimes if there's a chronic ectopic, it just gets encapsulated and you're not going to be able to see anything. So it's not that always there's going to be fluid, but yes, there could be. And if you see over here, I mentioned in a few cases you're going to be looking at. Sometimes the fluid could be really up to the liver and the right kidney. Sometimes you could just be looking at 30 to 40 ml, depending on at what time or how soon are you catching or the patient has come to you.
Thank you. Thank you. Thank you so much, sir. So friends, if there are any questions, you can write in the chat box. So meanwhile, I am going to take the non-academic portion. Sir, as my show's name, the icons in conversation with Dr. Ritu. So we have finished the one round of the academic session. We know you are the master blaster, teacher of teachers. So there is lot of appreciations we are getting. Now, sir, we are coming to the non-academic portion. Here I am going to ask you some questions which you have to answer in one word without thinking much. Okay. These are the normal questions. Yeah. So this is a surprise. I never share with these questions with any of my faculty members. So whatever come in my mind, that time only start I will ask. So you are role model for so many of us. So many of us want to be a sonologist and perfectionist like Dr. Kuldeep Singh, sir. Sir, who is your role model?
In terms of role model, I would say I've been trained under Dr. Khurana, so he's my role model. Otherwise, I went into this field because I like this, and then we had our teachers who used to explain us. Dr. Suresh is there from Chennai. So these are the people whom I look on to. Dr. Narendra Malhotra has helped me so much. So that's how they all have been the stones or the stepping stones for it's okay. Kuldeep, you go ahead. We are there with you.
Great, great. Sir, which is your favorite color?
My favorite color is black.
Okay. Sir, you are a tea lover or coffee person?
Tea lover, absolute tea lover. And tea lover means I have 15 glasses of tea at least a day. And that's usually in a steel glass. I don't have it in cups because that way, even if I'm doing a level 2 scan and after the level 2 scan, now more for Corona, I need to be wearing a mask so that it remains warm.
Okay, okay. Sir, one of your favorite places where you have visited?
I have been to Atlantis, that's in Dubai, and I really love that. Otherwise, I am more of a Goa person, Jay.
Everyone loved Atlantis, sir. Whosoever visited once.
Absolutely. So, that lazy river is very good, and you can just, with the kids, it was always and always good fun.
Great, great. Sir, you like this winter or summers?
Winters.
Winter. Your favorite fruit?
Mango. Because okay. I'm from Lucknow, so mango is the Shahri Aam is the best.
Great. And sir, any message for the upcoming doctors those who want to be specialized in this field. So what the message you want to give for the young upcoming doctors?
I just want to give one message, and that is you need to have a passion. You need to have a passion that I am going to be doing it. That is the message that I always and always give, and never be in a rush. That okay, in 2 days time I should be able to learn everything and I should be able to. It's not easy. It's not easy. You need to have the passion that I am going to love seeing these babies, and that's what. And that's what I always say in Sonu school is the eyes are going to see what the mind knows. And one plain simple thing, anyone can do it. You definitely can do it. There's no thinking about it.
Great, great. And as sir has also mentioned, we have to be involved more and more in the academic discussions. पढ़ तो सब कोई सकता है book से. My aim of starting this educative programs is like that only. What the difficulties I have faced in that time. So now the upcoming generation who is coming don't feel such difficulty. Now the social media is so strong. We can approach so many doctors and so many seniors like Kuldeep Singh sir who are very supportive. I must say, whenever I approached Dr. Kuldeep Singh sir, मेरा और सर का कुछ ऐसा रिलेशन है, सर मुझे कभी भी नहीं बोलते हैं. So I am always grateful to you, sir. मैंने जितने भी programs किए हैं, all the programs the sir has come. In spite sir is having a very busy schedule, sir take out time for me. So thank you so much, sir, from the bottom of my heart.
Always a pleasure, Dr. Ritu. Always there for you.
Yeah. So if there are no questions, we will wind up for today. And friends, do stay tuned on next Thursday, 17th November, same time, 8:30 p.m. Indian Standard Time. We are having with us Dr. Nasreen Sheikh, all the way from the Dhaka, Bangladesh, CEPOC secretary. She is going to discuss with us a very important topic, the osteoporosis in the menopausal period. So what is the new advancement? What is the new guidelines have come for the menopause management in the menopause for the osteoporosis management? So do stay tuned on next Thursday, 17th November. And on the 24th November, we are having with us Dr. Kavita Bapat, madam with us. Madam is going to discuss with us the role of the artificial intelligence in the obstetric and gynec practice. So do stay tuned with us with many more interactive discussions. So till then, bye-bye friends. And thank you, Sheel Pharma. Thank you, Dr. Suman. Thank you, Chitra, especially for making the program live on the YouTube. Once again, thank you so much, sir.
Thank you so much, and hats off to you, Dr. Ritu, for planning such talks and all that. This is really lovely. Lovely, great.
And very important, many thanks to my all dear friends who have joined all across the globe. Without them, how can this program become a successful? So till then, bye-bye.
Thank you. Bye-bye, Ji. Take care, all of you. Bye-bye,
Thank you,
Ji.
sir.
Bye-bye.
Yeah.
Thank you, Dr. Suman. Thank you so much.
Thank you, sir.
Yeah, bye. Thank you, Sahiti too.
Thank you.
Yeah, bye.